I am Adrienne Windsor, and I'm happy to welcome you here tonight. What a great turnout we have on a rainy night. I'm so amazed by this community. You're stalwart individuals. It shows your commitment to your health as well. So this is a program that is sponsored by the Library Foundation in conjunction with UCI Health. And our speaker, of course, tonight is from UCI Health, but also from the Gavin Herbert Institute. And I just want to tell you that Medicine in Our Backyard was born in Dr. Steinert's office at the Gavin Herbert Institute. He was the founder of that institute. And Mike and Polly Smith, who've been our sponsors for years, ever since its inception, were there in that office. And we were saying, wouldn't it be wonderful if we could share with our library community these incredible doctors that you have working here at UCI? And that's how it began. So we've kind of come full circle tonight to have a speaker who is with the Gavin Herbert Institute. So how many of you are members? Okay, some of you aren't. I hope before the evening's over you might consider joining, or that you'll go home and look at our website. As Jerry said, we sponsor so many different programs: the Woody Lecture Series, Library Live, Spotlight on Science, the financial workshops, the book discussion group, and of course Medicine in Our Backyard. So it's a really vital part of the education of our community. And I don't know if you know this, but the library, the Newport Beach Library, is the second most visited place in Newport Beach after the beach. Which is pretty astonishing if you stop to think about it. All right, so I wanted to announce Kunga has a new baby. Last time I said she would be here for one more meeting, and she's not. She delivered 2 weeks early. She will be back probably in February, but she's already sent me the script for January 26th. And I'll tell you right now that that will be our next meeting, and it's going to be on keeping your weight under control, which is perfect right after the holidays. So, and let me also say that these lectures are recorded and they are available on our website and on the YouTube channel. So if you would tell your friends about it so that people who don't make it here can learn the things that we are learning. So if you would please silence your cell phones right now, I'd appreciate it. And after our speaker, I will be coming around with the microphone so that you may ask questions. And I'm going to ask you to speak into the microphone because it is recorded and it becomes a part of it. And if you will ask your questions generically rather than specific to your own particular illness, because it is going to be on YouTube. All right, so I think I've covered everything there. Let me get down to our speaker tonight. He walked through the door and I said, oh my gosh, he's just a kid. But of course he isn't. He's just that much younger than most of us here in the room. He's Dr. Andrew Browne, and he's a board-certified UCI Health ophthalmology specialist who specializes in the diagnosis and treatment of macular degeneration and other disorders of the retina and vitreous. Dr. Browne received a medical degree from the University of Cincinnati College of Medicine in Ohio, and I have to tell you, he also went to Ohio State, and I'm a Michigan graduate, so you know there's a little conflict there, but I've taken him into my heart anyway, so it's all right. Anyway, he earned a PhD in electrical and computer engineering at University of Cincinnati. That's a long way from ophthalmology. He'll have to tell us how he decided to pursue the career that he did. He completed an internal medicine internship at Cambridge Hospital, a teaching affiliate of the Harvard Medical School in Boston, followed by ophthalmology residency at Los Angeles County USC Medical Center, where he developed an interest in diseases of the retina, inflammatory diseases of the eye, and ophthalmic tumors. Next, he completed a fellowship in vitreoretinal surgery with an emphasis on uveitis, the Cleveland Clinic Coli Institute in Ohio. So please join me in welcoming Dr. Browne.
It's really nice to have so many people out here tonight. This is more of an Ohio rainy night, so it's nice to have people that are willing to brave the storm. My face kills my credibility on a daily basis, but I recently became at least more than half the age of most of my patients, and I'm 46 now, so that's where we finally are. Yeah, tonight I'm going to talk to you a little bit about a very common disease. I saw probably about, I don't know, 12 or 13 people this afternoon with macular degeneration.
Just a little louder.
Sure, yeah. Nobody else can hear me in the back? Everything okay? Okay, that a little bit better? Great. So, yeah, I saw about 12 or 13 people this afternoon in my clinic with macular degeneration. So it's a pretty common disease, especially in a retina specialist's office. So for most physicians, the eye is kind of an enigmatic part of the body. In fact, I didn't even get a lecture on the eye until I was in my end of my third year of medical school and really started to understand what it is. And so most physicians tend to be overwhelmed by the thought of anything being a problem in the eye. So I thought that I would start off by kind of giving you some background and understanding of how the eye works, and then we'll get into what is macular degeneration, this very common problem. Can you guys still not hear me okay? Okay. I'm going to stand off to the side and have this thing right in front of me, and maybe it'll be a little bit better. Most of my patients tell me that they're hard of hearing, but I'm also hard of speaking, so thanks for the feedback. I appreciate it. So when you're driving down the freeway, there's a lot of things that you can see and things that are really important, something like a sign that tells you where to go. You read that sign with your central vision. And everything around on the sides of the freeway is important because you want to see if a car is going to cut you off from the side or if someone's going to run in front of you. So your peripheral vision is critical as well. And the picture that I just showed you was taken by a camera. Most people are familiar with what a camera is. Most younger people don't know that a camera used to look like this. But there's usually two lenses at the front of the camera. That's the blue and yellow lens. And then, of course, there's the film in the camera, or nowadays a CMOS or CCD sensor. And that takes an image. And that image has the same resolution throughout the entire image. It's clear everywhere. Interestingly enough, it's not quite as clear as our central vision is, but it is more clear than our peripheral vision. So it's a pretty impressive image. Well, the eye is really not too dissimilar. And at the front of the eye, we have the cornea. That's the blue thing up there. The yellow thing is the lens inside your eye. That's what becomes a cataract as we get older. It becomes less clear with time. So there's a surgery where we go through the cornea, use a little bit of fancy ultrasound energy to take that lens out and put a new plastic lens inside the eye. That's all the optics of the eye. The cornea and the lens are both critical for focusing the world onto the retina, what I consider the most important tissue in the body. And so the retina is that orange thing, that orange wallpaper that's inside the eye. Of course, the eye is a sphere, and so it covers the whole inside of the sphere. And then all the information from the retina is conveyed through the green thing, the optic nerve, back to the brain. And the brain is what perceives the natural world around us. So when we think about what the eye sees, it's not like the photograph that I showed previously, but it's more similar to what you're seeing here. It's very clear in the center, and it's blurry towards the periphery. The center is really good at seeing color and fine details. The periphery is really good at seeing fine movements. That's why oftentimes you can look up in the sky and all of a sudden your eye will be able to find this very faint airplane flying across the sky. So my two little kids, which by the way, we were just here on Sunday. This is the best place to bring them, and we're so grateful for this resource. My two little kids look up in the sky like, boom, airplane. I'm like, how did you see that? Their eyes are better than mine. But they're able to see that because their peripheral vision is able to see small amounts of movement in the peripheral parts of their vision. So we have central vision and we have peripheral vision. So I'm going to talk a little bit about the aging eye. And the first thing is presbyopia. I'm 46. Unfortunately, I'm starting to enter a place where my arms are getting shorter. So, of course, I have to hold a book further away or my phone further away from my eyes to be able to see. I see some people wearing glasses. You may wear reading glasses as well. So presbyopia, there's no cure for it. It's reading glasses, or if you have cataract surgery, you might consider a multifocal or extended depth of field lens. And these are fancy lenses that try to give you a little bit of close, a little bit of distance. If anybody can fix presbyopia, that's going to be the biggest thing that we can fix in all of vision problems, because it affects people from their 40s until the end of their life. Then there's cataracts, which I mentioned previously. That's when the lens inside the eye becomes less clear over time. Oh, I'm sorry, this is not synchronizing exactly with what I'm seeing up there. So the dry eye is what most people feel as grittiness of their eyes. That's when the tears on the surface of the eye change in quality over the course of our lives. Just because you have moisture in your eyes doesn't mean you don't have dry eye. Moisture in your eyes is a natural reflex, kind of like hitting your knee and your knee kicks out. When your eye is dry, there are more nerve endings on the surface of the eye than anywhere else in the body, and they detect a problem. Because if your eye is dry, you can't see clearly. And so what happens as we age is we can still produce the liquid moisture, but our eyes don't produce the same amount of sugars that hold the liquid on the surface of the eye, and oils like a cactus that covers the thin film of liquid to stop it from evaporating. So then all of a sudden you just have lots of liquid that's just evaporating. Cataract, I mentioned already, is when the lens becomes less clear with time and can be replaced with cataract surgery. Age-related macular degeneration is what I'm going to focus on primarily tonight. And it's a common disease in the aging population. And then finally, glaucoma is a condition that affects the optic nerve. It's where you typically hear people talking about constriction of the visual field over time. People may have no idea that glaucoma is occurring until even they lose their central vision, because you can be 20/20 crisp vision until all of a sudden it can be gone, and it can be devastating. But it happens over decades, as does macular degeneration. Takes a long time to develop. So here we have our central vision and our central vision, which is critical for seeing things under low light conditions. And I'm just going to turn around so I can make sure that I'm seeing what it's showing at the same time. When we have a reduction in our contrast vision, we can't see white letters on a black background as well. We definitely can't see white letters on a gray background, as what we see here. That's what happens.
Would it be easier for you to use this?
Yeah,
And
I think
you can
that.
turn around.
Perfect. Oh, that's even louder. Great. So, as you can see, this is a reduction in contrast. Certainly wouldn't want to drive down the freeway with reduced contrast in your vision. Not a big problem on a sunny California day. Really big problem right now or at dusk. So here we have low light conditions, dusk, and then bright light conditions, where you can clearly see that there's a big difference in your ability to perceive the letters on the sign. And under low light conditions, that things get even worse. So similarly, the same thing happens as with a freeway sign as with a book. So people with macular degeneration will say that they can't see the letters very clearly. When you come to an eye doctor's office, we talk about 20-something or other, 20/20, 20/25, 20/30, 40, 50, 60, up to 400. 20/20 means that you can see at 20 feet what most people with normal vision can see at 20 feet. 20/40 means that you can see at 20 feet what most people can see at 40 feet. 2100 means a normal person with normal vision can stand 100 feet away and see what you have to see at 20 feet. So it just means that the letters keep on getting bigger and bigger. And so this is how we measure vision in the eye clinic. And so when you think about reduced contrast, you obviously have black letters on a gray background or under low light conditions. It can be really hard to read without adequate lighting. And as macular degeneration progresses, the contrast in your central vision gets worse and worse. So now you can barely even perceive the letters in your central vision. But under bright light conditions, it can be a little bit better. So even with a reduction in contrast, if there's bright light, you can still make out what some of the letters are centrally. So this is what people might recognize as one of the first symptoms of macular degeneration. They might say, when I go to a movie theater, it takes me 5 or 10 minutes before I can see anything. That's a delay in dark adaptation. How long does it take you to adapt to dark light or low light? Another component is the notion of metamorphopsia. Straight lines don't look straight. They can look kind of wavy or curvy or bent. And so if you're trying to read small letters and you've got reduced contrast, you can see how the combination of wavy letters and reduced contrast can become a two-edged sword. So when you come to see a retina specialist like myself, what do? We focus on that yellow line, that wallpaper inside the eye of the retina. And we can take photographs like this of the inside of the eye, and I'm not sure if this, I'm not sure if that laser pointer works. But what you can see is in the central part of the image, that's where our central vision is. That tiny little area right in the center, it's only 500 microns, half a millimeter. I can't even make it that small. About half of our vision comes from that tiny little spot in the back of our eye. Imagine taking a large ballpoint pen and just touching a piece of paper. That's where half of our vision comes from. All that high acuity color vision comes from a tiny spot. And the rest of the orange that you see is moving away. I think the battery might have died. I'm going to switch back to this. It's got a little bit of arthritis in this microphone here. The rest of the vision is the peripheral vision coming from all the orange areas outside. You see some squiggly little veins and arteries. Those supply blood to the retina. Underneath the retina is a sea of blood vessels that also provide blood flow. The retina is so intensively metabolically active that it needs to have a ton of blood bringing oxygen and nutrients to it constantly. And in fact, if there wasn't a lot of blood flow, like fluid flowing through a radiator, it wouldn't be able to dissipate the heat quickly enough. Your retina might burn itself. It would get so hot. It wouldn't be 37 degrees Celsius. It would be on fire. Well, probably not on fire. I'm being a bit hyperbolic. So here's that large image. And you can see that there's a little sun-looking thing where all the veins come together. That's called the optic nerve. And that's where every single cell in the retina converges to send 1.2 million wires back to the brain. And that's how we get our information to our brain so we can perceive. So a lot of people ask me, what about just plug and play? Let's just put a new USB in there and let's try to get a new eye. And the reality is, can you connect 1.2 million microscopic wires? It's a really big challenge. And there's something super audacious that's going on right now, funded by ARPA-H, and that is to perform a whole eye transplant. And we have 2 researchers at UCI, one that's actually going to be starting in June, one that started in August, who are taking on this challenge of how do you transplant a human eye and direct the nerves through the optic nerve, that little circular sun over there, back to the brain. And how do you make sure that there's blood flow to all those arteries in the eye and to all of the arteries underneath the retina? And how do you make sure there's blood flow all the way to the front of the eye where those, more than any other part of the body, nerve endings feel dry eye, that they can feel dry eye? It's an incredibly audacious thing, but it's become a real conversation. And I'm hopeful that we are transplanting eyes at the end of my career that can take someone from no perception of light to perceiving light, or maybe being able to move their eye and sense the wind blowing on their eye. I think that's not unreasonable in my career, which is, I'd say I've got another 20 years to go. So the macula and the periphery. The macula is the central part of your vision. The periphery is what we talk about primarily in glaucoma, but we're going to be focusing on the macula tonight. So when you look at the eye in cross-section, you've seen this picture before. We're going to make that orange line that was there before into several different colors, orange, green, and red. And we're going to zoom in a little bit more. And the orange thing is actually the retina. That retina is a multi-layered cake. It's got 3 layers of cells. There's about 60 different types of cells in the retina, probably a little bit more. But we really talk about 10 different major categories of cells in that layered cake in the orange line there. Underneath the retina is something called the pigmented epithelium. It's the foundation of the retina. It's the cells that take nutrients from the red line underneath where all the blood flow is, and take all the nutrients and pump them towards the retina and allow us to have continuous vision. It's amazing that we can continuously see high resolution for over 116 years old is the oldest person alive right now. It's amazing that that can continue. It's amazing that the cornea, the front part of the eye, can remain clear like glass for over 100 years. It's an incredibly dynamic environment with incredible energy requirements to keep it going for a long time. So we have this blood supply underneath the retina going through the green layer, which is the support foundation, bringing vitamin A and other nutrients that are required for visual perception, and constantly taking all the byproducts, all the garbage that's produced by the retina, and taking it back to the blood flow and taking it out of the body. Because if it's metabolically active, it's got to be burning things up and having waste. And that waste is a big part of what is macular degeneration. So we have retina, the foundation, and the blood supply. And if we zoom in even further, we can see that in clinic, I saw 20 patients today in clinic in the afternoon, and I had an image like this on every single patient. And you can see in this picture, it's a black and white picture, but you can see multiple layers of the cake. This is an incredibly integrated neural network where light is perceived in the bottommost layer, right above that bright white line. Photons of light are captured by those cells, and they're converted into a neurological signal. And there are a host of proteins that are critical to allowing a photon to turn into a neurological signal that reaches our brain. And every one of those proteins can have a mutation, and that can cause a blinding disease. And among those mutations, there can be 300 different mutations that are unique to a specific person. So solving blinding eye diseases is a really significant challenge. But we're also on the cusp of being able to address these things in a personalized way, where we can interrogate someone's DNA, which is the script that tells our body how to function, find where the spelling errors are, find that one letter O that is supposed to be an A, change that letter O into an A in a technology called genome editing. Not just putting the right whole gene with hundreds of individual letters in it, but actually finding that individual letter, taking it out, like with the precision of a surgeon, and replacing it with the correct letter, and hopefully preserving vision. So this is the image that I get on every single patient every day. It allows me to see in microscopic anatomy, the microscopic anatomy of the retina, to identify problems. So the thing that I want you to focus on here is this very bright white line. Let me see if I can actually move my mouse over. Oh, look at that. This bright white line here. This is the foundation. This is that green line that I was talking about previously. And right above that is the photoreceptors, the cells that turn light into a neurochemical signal. And so the light shines into the eye through the fovea, the central high acuity area. Neurochemical signal is initiated, goes back in the opposite direction, and goes to the optic nerve and back to the brain. Isn't that incredible? You can get an image like that in 10 seconds. Every single patient walks in the door. The technology is called optical coherence tomography and was developed about 25, 30 years ago at MIT. And it was based on something called the Michelson-Morley experiment. You may have heard of that about that at Mount Wilson, where they measured the speed of light. Took a ray of light, shot it to two different Mount peaks, Mount Baldy, and another one I don't know, and they looked at the light as it came back, and they were able to tell from its coherence how fast did it travel. Well, now we have that little experiment happening hundreds of thousands of times in every single image as we scan the laser through the retina to get an image like that. And this overlay here shows a histological, if I took a piece of retina, I cut it into a very thin slice, and I looked at it underneath a microscope with some stains that stain at different colors, you can see how we can see the individual layers. All that purple are individual cells overlaid into the retina. And when we think about the retina, we have the inner retina, which conveys the blue signal, goes all the way to the brain, and then we have the the green part of the retina, which is the photoreceptors. And you can see all these different cell types that I was mentioning earlier. This is just a very broad categorization of the different cell types. But in the fovea, in the close to the fovea, in the further from the fovea, and far in the periphery, these cell types vary so drastically. So the development of the eye is an incredible thing that occurs in utero, and it continues even as a child reaches 4 or 5 years old. So when a child is born, they're not seeing high acuity 20/20 vision. They're seeing maybe some movement, and eventually they can see a smile on a parent's face, and eventually they can start to read letters, and eventually they can read the small letters. And it's a tremendous amount of blood flow. So I've been going over this quite a bit, but I want to move on to macular degeneration. You've had your anatomy part of the lecture. I hope I kept you awake for a little bit of that. But now we're going to move on to what is normal and what is abnormal. Well, this is, on the right-hand side, the normal anatomy. And you can see a color picture, just like the iPhone. I can take that picture with an iPhone, just put a lens in front of the eye with a little bit of light shining from the camera, and we can take that same picture. Well, if you look on the far left, you can see that it doesn't look quite as orange and uniformly orange. It's got some yellow areas, some brownish areas, some dark areas. And this is an eye with advanced macular degeneration. And this is the OCT image. You can see the foundation is really poorly damaged. And that corresponds to loss of the foundation cells that traffic nutrients and toxins to and from the photoreceptors, and loss of photoreceptors. So this is very advanced vision loss. This is where someone would have lost their central vision, the ability to see someone's face standing in front of them. And so when we talk about macular degeneration, you may have heard of dry and wet macular degeneration. Everyone starts with dry macular degeneration. It's aging, and it's how our body was able to get rid of the toxins that are produced from normal vision. And so I liken this to, a sinkhole versus a flood. Wet macular degeneration, it can be fluid building up in the retina because of damage to the retina. So the question is, how do we maintain the foundation of the retina? Fix the cracks in the house. So I'm going to go through kind of the progression of the condition. So in this is a color photograph of the inside of someone's eye, and you might be able to see these little yellow flecks. This is the very early stages of macular degeneration. The yellow flecks are garbage. We call them Drusen. It's a German word meaning bumps. And this is the accumulation of garbage underneath the retina, and the foundation is unable to get rid of that garbage. The blood supply is unable to get rid of it, so it builds up. And you can, everyone here lived through the pandemic, thank goodness. We all wore masks. Did you enjoy breathing through a mask? No. So if you can't breathe through a barrier, imagine how the retina struggles to breathe through something that's stopping the natural flow of critical nutrients. And so cells struggle. So that's the early stages. Then you can get large drusen that accumulate, and you can get many of them, and they can be throughout the whole central part of the vision, in the macula and in the fovea. And this is, again, the normal cross-sectional view from an OCT, and that's what the drusen, the large big ones. Yeah, please.
Do you equate this to symptoms?
Yeah, this is the contrasts and the distortion, the metamorphopsia, where things look like they should be straight lines, but they look wavy or curvy or distorted. And it's the trouble going into a movie theater and adapting to dark, or reading a book under low light conditions, or driving at dusk. This is what these people might. This could be very well be a 20/20 eye. And the only thing people complain about would be, well, I have a hard time reading my book at night in my bed, or I struggle at dusk with driving, or I can't go into a movie theater and find a seat. So, yeah.
What is the dip in the retina?
Yeah, that's the fovea. Great question. So that's actually where all of our central vision is. That's 500 microns across, half a millimeter across. And that's very little tissue on the surface of the retina, because if you want to see things at high resolution, you don't want the light to have to shine through a lot of other layers of tissue and get scattered and decrease our acuity. So, dogs and horses and cats and other animals, they don't have a fovea. Eagles have 2 foveas. Other primates have afovea, but primates have high acuity vision. So, dogs and cats are like somewhere 20/40, 20/50 vision, horses 27. They have higher acuity areas, but it's nothing like what a human sees.
So that's not damage to the retina.
That's normal. You would definitely want to see that. And the only damage that we're really seeing in this image here is this accumulation of waste material underneath the retina. And then when we progress to wet macular degeneration, you can have bleeding. The foundation breaks, and new blood vessels grow. I always use the analogy of a sidewalk sitting in the sun for 80 years. Gets a couple cracks. Some weeds can grow in those cracks. We can spray some weed killer on them and kill the weeds, but they can always grow back. So when new blood vessels grow, which is a natural response to a wounded tissue, new blood vessels try to come and help things out, because that's what our body does, to try and make sure that we have skin our whole life, to make sure that our muscle, when it tears from lifting a heavy thing, can recover. It's a natural response, but it's not a healthy response, because it actually ends up damaging the eye further in many cases. And so here we see an eye that's got blood over here, and there's just a tremendous amount of damage and scar formation. And if you take the normal image of the retina and you compare that to someone with wet macular degeneration, this is a pretty bad case, where you can see that there's pockets of black fluid within the retina. You see a large separation of the foundation of the retina from the blood supply. And this completely takes away one's ability to see clearly. People definitely become symptomatic at this stage.
So dry is better?
It's never good to have, but wet is in some ways treatable. Let me tell you a little more about dry here, because this is actually the severe form of dry, which was in the picture before. This is where we have death of the foundation and the photoreceptors in the central part of one's vision. So there is actually central vision loss in a way that we can't reverse it yet. And I'll mention some things later for how we might address this in the future. But so advanced macular degeneration is not a good thing. This is advanced dry macular degeneration. There aren't any new blood vessels that are bleeding and leaking, but there's an absence of tissue that turns light into a signal that we see. And so when we look at a cross-section on the OCT, this is what things look like, where you can see the foundation is completely damaged, and there's actually no foundation over here. And you might be able to say that over here things look different underneath the retina compared to here, and then over here goes back to normal. And that's because light just shines right through, and no vision can be initiated in this area. So I'll talk about all the different types of treatments that we have for all the stages of macular degeneration. So what do we tell people to monitor if they have early or intermediate macular degeneration, or even if they have wet macular degeneration? We give them a piece of graph paper, or we can say, look at the blinds in your house, or look at the contour of your door frame. It should always be straight and at right angles. And we have people look at the little black spot in the center of the graph paper, and we have them focus on that black spot. And if all the lines that are around the black spot, without moving your eye, using your peripheral vision, are straight and at right angles, then it's likely to be normal. Or at least that's your baseline. If it changes from that, then we get concerned. So one of the technologies that was discussed a lot about 10 years ago is this screening tool where people would look inside and they'd see some moving lines, and they'd look for these kind of just changes in the shape of that line, some distortion. And if someone had an abnormal test result at home, then it would notify their physician to say, hey, come in, we need to take a look more closely. And more recently, the discussion has been had about putting these home OCT scanning laser instruments into the home so that an image can be acquired in the home. This is the image that would be acquired compared to a clinical image, very similar. And artificial intelligence would be used to detect abnormalities and notify the physician that therapy was needed. So we're going to go through how do we manage all the different stages of macular degeneration. And of course, prevention is everything. In fact, the only thing that helps everything is diet and exercise. It doesn't matter if you have a cardiologist speaking to you tonight, an ophthalmologist, a neurologist, doesn't matter. Every condition in the human body is treated best by diet and exercise, and in early life. So when we talk about prevention of macular degeneration, there are these modifiable things that we can do. Of course, we can have a great diet and exercise. Cigarettes guarantee that your macular degeneration will be worse if you're susceptible to developing it. So there are some people who have inborn variants in their DNA that you can call them mutations that predispose them to developing macular degeneration. My dad had it. I'm likely to have it. I never smoked. Good thing. But also smoking has kind of fallen out of favor. All the more so here in California because it's been illegal to smoke in public buildings for, I think, 20 years. So smoking is the number one thing that one can modify. But in other parts of the country, smoking is far more prevalent than it is here. So this is why we always make sure that if a lecture like this is being recorded, that is being said. It's critical that people know that if they smoke or if they're exposed to secondhand smoke, even if they're as kids their parents smoked, that increased their risk of developing macular degeneration. High blood pressure and cholesterol, hypertension, HTN, and HL, hyperlipidemia. You know, these things affect the ability for blood to flow to every organ in our body. Naturally, it affects the most metabolically active tissue in our body, in our retina, in our heart, in our optic nerves, in our brains. So if you control hyperlipidemia and hypertension over a long period of time, then you're less likely to have as severe macular degeneration and cardiovascular disease as well. There's certain things that one can't control. You can't control where you were born, who you were born to. So that's something that I think about. There are people who have certain shaped eyes, hyperopia. That's a refractive error, a certain shape of the eye that can predispose you. If you are female or if you have blonde hair, blue eyes, a little bit more than men who are blonde hair, blue eyes. A little bit more people who are men who are brunettes with brown eyes. But there are plenty of people in South Asia that have macular degeneration. My wife is Sri Lankan. She's got uncles with macular degeneration in Sri Lanka, and they don't look like your Southern California Newport family. So it can affect any group of people. So how do we slow progression? Well, once we know someone has macular degeneration, we track it. If you have early macular degeneration, we see you every 9 months. If you have intermediate macular degeneration, you see someone every 6 months, advanced every 3 months at least, or more, depending on the activity of the condition. So the food pyramid is up here because it's the most important thing. If people consume 2 to 3 servings of fish per week, and when I say fish, I'm not talking about, cod and that sort of thing. I'm talking about fatty fish from the ocean, things with a lot of omega-3 oils in them. Those are the fish that have been shown in large, prospective, government tax dollar funded studies to slow down the rate of progression. Same thing with cigarettes. So there was a series of studies called the age-related eye disease studies that started, I think, in the 90s and continued into the 2010s, where they studied cohorts of people, and they looked to see what were the environmental factors that contribute to worsening of macular degeneration. And if you have a Mediterranean diet, I'm from Ohio, so it's very different from a Mediterranean diet. In California, there's a lot more people who, especially in Orange County, people who are on Mediterranean diets. But if you're on a Mediterranean diet, it is superior to any other diet for macular degeneration. And guess what? It doesn't matter if it's a cardiologist, a neurologist, it affects every part of the body critically. So all of my patients I encourage to eat fish 3 times a week. That means tuna, salmon, lobster, shrimp if their cholesterol is not too high. Sardines are great. You can have some trout. Sea bass is great. You can go on Google and say, which fish have a lot of omega-3, and order that when you go out to have a meal. The age-related eye disease study also identified that there's a vitamin cocktail. This is not just peddling vitamins and trying to say, hey, you're going to get healthy and you're going to be great. No, this is actually data-driven studies where they said, these people are going to get vitamins, these people are not. And when I say vitamins, I really mean supplements. Zinc, copper, lutein, zeaxanthin, vitamin C, vitamin E. Those are the new supplements that are included in the AREDS, Age-Related Eye Disease Study cocktail. Most people who know the names are Ocuvite and Preservision. Preservision is what most of my patients take. A lot of people will go to different providers in the community. They have some custom-tailored cocktail of these same things. Maybe it's called Macular Health and other things that they say is good for your eye health. The age-related eye disease study studied a large cohort, hundreds of people, on this cocktail. So that's what we have, good, strong data to say this will help you. We only recommend the vitamin cocktail for people with intermediate or beyond macular degeneration. There was no evidence that initiating it in the early stages improved vision over time. So we only initiate it. And a lot of people say, hey, I've got early, or my dad had macular degeneration, maybe I should just start it. I'm not taking it. And in medicine, we're not supposed to do harm. In Orange County, we have a much higher income per household. But if I told you that macular degeneration vitamins cost $60 a month to $80 a month, or maybe you got lucky, you got it for $40 a month from Costco or something like that, how much is that in a year? I would gladly take $500 a year. So we don't want to just be telling people to take vitamins with the hope that they're going to improve themselves unless we know that there's evidence that suggests that there will be benefit. So for intermediate and beyond, we recommend vitamins. For anybody with macular degeneration, we recommend Mediterranean diet, fish consumption, whole grains, nuts, green leafy vegetables. This is a very Southern California diet already. But these things slow down the rate of oxidative damage to the retina. And over decades, not just 5 years or 2 years, but over decades of having a lifestyle like this, that's what sets you up for your whole life. So for my patients that have macular degeneration, it's very hard to manage their condition because it's an emotionally challenging thing. You know, I grew up reading about the blind in the Bible, and that was my biggest fear as a 4 and 5 and 6-year-old, was thinking about losing vision. It's a terrifying thing for patients in my clinic. But it's really critical that they also share with their family, if they have macular degeneration, that their family can have decades of impact if they start with appropriate timing soon enough. So, Mediterranean diet, whole grains, nuts, green leafy vegetables, lots of fish. Unfortunately, taking a fish oil supplement, which is great for dry eye, has not been shown to be as beneficial as eating from the fish. Don't know the mechanism. I wave my hands and say I think it's a bioavailability thing. Something about it coming from an animal helps with absorption and distribution. I don't know the answer. So finally, what is the therapy? Well, when it comes to people with advanced macular degeneration, this is the advanced dry or advanced wet, there are injections. Historically, there were lasers. So here's the timeline of the age-related eye disease study. And I've kind of talked about this a little bit already, but basically in the last 15, 20 years, we've been strongly recommending this AREDS 2 vitamin formulation to prevent people from getting to advanced dry or advanced wet macular degeneration. What is AREDS 2? Well, AREDS 1 had beta-carotene in it, which is vitamin A-ish. And beta-carotene in people who smoke increases the risk of lung cancer. So the simple solution is nobody take the AREDS 1 formulation anymore, take the AREDS 2 formulation, which is what they sell.
Is that an oral medication?
Yeah, it's an oral one. And here's actually the comparison of AREDS 1 and AREDS 2, and this is what's included in there. It's a fairly large pill you take twice a day.
You talk about dry eye, but there's outer dry eye and then there's inside dry eye, right?
When we talk about dry eye, we're typically talking about the surface of the eye.
The surface.
Yeah, this is dry
About inside the retina.
dry macular degeneration, which is a very different, it's an anatomical description.
But there's dry outer eye and there's dry inner eye.
The word dry is used to describe different conditions, and so it is very confusing. And most people have some amount of dry eye. I do too. And we use artificial tears to lubricate the eye for dry eye. That will not help your dry macular degeneration, putting artificial tears on. So the word dry is used in both places, but
Dry
just
retinal and dry outer.
yeah. We talked about the diet and how we need to turn the Western diet upside down to achieve what we really need to have. So we talk about slowing the progression. And so what I was mentioning previously was we talk about giving AREDS vitamins to people with intermediate and beyond macular degeneration. So here's intermediate, and here's advanced dry and advanced wet. This is where we give the vitamins. There's no really great benefit that's been demonstrated in the earlier stages. Mediterranean diet, always. But what happens if someone's got wet macular degeneration? Then we start talking about something that is, people think of horror films, but I can promise you that it doesn't have to be a horror film. It actually can be easier than getting your teeth cleaned. And I had my teeth cleaned 2 weeks ago, and I really did not enjoy that experience. But I had one patient today that gave them the first shot they've ever had, and they said, "Did you give me the shot yet?" And I said, "Yeah, we did both eyes already." So it can actually be not the horror film that you think of, having a needle stuck in your eye. We numb the eye up. We don't want pain when people have to have this treatment. And they have to have the treatment monthly, possibly, for even years at a time. Some people can go to every 2 or 3 months. But it's a part of their life. So it's really important that people don't have a really negative experience when they get their shots in their eye. But what is the shot? It's a medication called antivascular endothelial growth factor, anti-VEGF. And there's a whole family of these medications. We started injecting them in the 20-aughts. There's a very weak one that first came out. I didn't use it ever, but my mentors would say it's like putting eye drops in the eye. It didn't do a great job. But later, before 2010, there was, in 2005, there were a family of medications that became much more effective. And actually, they were born out of therapies that were intended for colon cancer and breast cancer. Cancers have new blood vessels that grow to support a tumor. And so these medications stop new blood vessels from growing. And so there were 2 medications that came out in the 90s, but really picked up in the 2000s for their administration in the eye. And a small dose, 0.05 cc's, 50 microliters, is injected into the eye after the eye has been numbed. And that medication diffuses throughout the eye, and it goes and finds abnormal blood vessels, and it tells them to be normal. It binds to their receptors and stops them from being able to develop. It actually stops them from being leaky blood vessels, from leaking fluid readily.
So you give it when it's wet?
For wet macular degeneration, exactly right. So here's an image of someone with fluid underneath the retina before an injection, and here's the retina after the injection. And people notice a significant improvement in their vision. So it's nice to have a therapy that can actually improve someone's vision and try and sustain it for years. When I said there were lasers initially used, in the 80s and 90s and 2000s even, first we were using a laser, like just burning those new blood vessels, and that destroyed vision at the same time. Then we moved to putting this dye that is injected into the vein and circulates throughout the whole body. You wait 10 minutes, and then we shine light onto the retina, and the dye makes the blood vessels change their dynamics and leak less. And that was the treatment for a very long time. And then, needle in the arm, wait 10 minutes, have a light shining on the eye. Way better than having someone blast you with a laser in your eye and take away vision but burn the blood vessels. But still, even after that therapy, you have to wear a hoodie, cover every part of your body for 3 days because the dye is in your body. And if you go outside, you can have a sunburn that kills you. So it's not a pleasant therapy. And so having this new category of medication that's been around for more than 20 years was a paradigm shift. In fact, the technology that you're seeing that took those pictures, this is one of the older OCT instruments. This technology and the injectable medications came out at the same time. It was a revolution in preserving people's vision. Otherwise, it was just lose your vision quickly, and there's nothing that we can do, and we can't really analyze it. But now we look for subtle, tiny pockets of fluid in the retina to look for subtle, early activity of the disease, and we can try and stop the disease from really blossoming before we react to it. And that's why people come back every 3, 6, or 9 months, so we can monitor these very subtle changes that can occur. because of this really fancy laser scanner and these amazing medications that have just changed the course. And they've been doing wonders for 20 years now. So how do people get treated? Well, they can find that they have activity of their disease, and then over a course of months, they might get a monthly injection. And we'll take another image, look at the response. Good response, but not enough response, another injection. And you keep on giving shots on a monthly basis until the activity of the disease is reduced. But some people have low activity disease, so they don't need to have a monthly injection. Maybe they need 2 injections first, and then we can go to 2 months, and then we can go to 3 months. And it can be very variable for different people. So that's why we try to tailor the treatment frequency for the activity of the disease. We can't just say, hey, you could come in for a shot every month. And that most people don't like that. Yeah.
Do different doctors have different protocol as to when they give these shots? I mean, is it usually when it's wet?
Yeah, so these shots are only indicated for wet macular degeneration, where there are new blood vessels that have grown and have changed the anatomy and leaked or bled. So these don't help with dry macular degeneration. These are only for responding to the fire of wet neovascular.
Some of the new medications, are they more responsive to, or are they all given when it's wet also?
Yeah, so these, on one of the previous slides, I showed that there's a number of different medications, on the bottom here. And I don't represent or speak for any of these drug companies, but I use their medications. But these are the ones that are available. And they all are amazing. And the newer ones are intended to try and have a longer effect. For some people, they do have a longer effect, meaning that maybe you can go 8 weeks before activity recurs. But for other people, there's a higher effect probably, but doesn't get them to be spaced out immediately.
Can we hold the questions until you're through with your presentation?
Oh, sure, yeah. Let's just hold the questions until I'm through the presentation, and then I'll be happy to take as many. Does this need to be recharged before questions? Let me go check. Okay, so these injections are, were really revolutionary. And my whole practice in ophthalmology has been since these injections have been available. I started my residency in 2012, about 10 years since people started putting these medications into the eye. And we're going to talk about dry macular degeneration injections right now. Before I talk about that, there's also something called a port delivery system that is supposed to be a reservoir for putting a volume of medication into the eye, into this little plastic pellet that is surgically placed in the eye, and it can be refilled every 4 to 6 months or so. So just to try and to reduce the frequency that people have to come and get an injection in clinic. It has not become widely used, but there are people who really like it a lot. I haven't had a patient who has wanted to have a surgery to put a plastic port into the eye that we can inject. They just say, I'll come back in for a quick shot. It's not a big deal. Testing. Actually, I should have modified this slide. I'm so sorry. This category of medications for dry macular degeneration, dry advanced macular degeneration, became available 2.5 years ago now. And so what we see here is progression of these dark areas are where the retina has died and vision is lost. And you can see how they expand over time. They will always expand. We have a new category of medications that are injected as well every 4 to 8 weeks, and they take the slope of the curve where the area of atrophy, the dark areas, gets bigger over time and shifts the curve. After about a year, it's about 20% difference maybe. And over 5 years, the effect is much more noticeable. But it's a very challenging medication to start using, because a patient will not appreciate any benefit. They will not have an improvement in their vision. They will just know that they're doing something to try and slow down the rate of progression. So if the atrophy is not in the central vision, but it's growing towards the central vision, that's when a lot of patients will be enthusiastic to come in for an every 4 to 6 week injection to try and preserve the vision. But we can't prognosticate, we can't guess how much extra time they will be given with their vision. Some of the longer term results are coming out and showing several months of added vision over a 5-year period, or maybe even up to a year in some cases. So the rate of growth is slowed in populations of 300 to 500 people that were studied in different cohorts to slow down the rate of atrophy progression. This is the first time in the last 2.5 years where we've had an option to do anything for people with this situation. We're optimistic that if we intervene even earlier, we can ultimately not have patients getting atrophy like this. And I would love to not have to do injections in clinic. And my patients would love that too. So what are the clinical trials that are ongoing at our eye institute, at Gavin Herbert Eye Institute? Well, there's two. The first one is, there's two that are for macular degeneration, I should say. There's plenty of clinical trials, but two specifically that I'll focus on. One is a treatment for advanced dry macular degeneration, where patients still receive the injection into their eye, but they can self-administer a subcutaneous injection, kind of like insulin dosing, on a fixed schedule at home, and the combination of that therapy being administered peripherally but circulating systemically, and the medication being delivered locally, is the question that they're trying to ask is there added benefit? Is there slower rates of geographic atrophy expansion? The other clinical trial, and one that I'm pretty excited about, is from a company called 4DMT. There have been a variety of there's a lot of clinical trials for wet macular degeneration at any one time. And we've been involved in ones for injecting a virus in a surgical procedure underneath the retina that turns the retina into a factory of medication for wet macular degeneration. So what this category of what this clinical trial is looking at is injecting adeno-associated virus, a common cold virus, that has been modified to go into cells and to turn cells inside the eye into factories that make the medication that we would otherwise be injecting. And so it'll be very exciting to see if we can actually reduce the treatment burden of wet macular degeneration with these. I'm optimistic that we can. And so that clinical trial is actually for people that are treatment naive and they've never had an injection before. There are stories of in the phase 1 and early trials where some people have gone from requiring monthly injections to not having an injection for 8 months to a year. So it's a very exciting time for this category of medications. And there's also other classes of medications that are not anti-VEGF, anti-vascular endothelial growth factor, that are injected as well that might reduce our treatment burden over time. So what can a patient with AMD expect? They should first of all not lose hope. It is exceptionally rare. I maybe have had 2 patients in 13 years that I've been taking care of people with eye problems that have lost all ability to see movement of a hand in front of their face, but it was in one eye. So it's not, losing your vision. It's not going no light perception. It might get to the point where you can count fingers in front of your face, but you will still have your peripheral vision. People can still have very full and happy lives with advanced macular degeneration. So it's really important not to lose hope. It's just about having the right expectations. And with wet macular degeneration, we can really sustain people's vision. The vision can decline and does decline over many years, but if we keep the activity of the wet macular degeneration low, then we can sustain 20/20 vision for a very, very long time. And we're also living in a time of innovation. I told you about one of these already: gene therapy, gene augmentation, to deliver DNA into the eye that makes medicine. So I'll talk a little bit about science for macular degeneration that goes on at UC Irvine. I was telling Adrian when I first came tonight that I came to UC Irvine without the expectation of knowing where I would be 2 years later, because my wife was doing she's an ophthalmologist as well, was doing a fellowship in San Diego. And so we were going to discover where we were going to go afterwards. And she's, very well pedigreed and extremely well trained and much smarter and more beautiful than me. And she could go anywhere. And so but seeing what was happening at UC Irvine and the Gavin Herbert Eye Institute was just transformative to the way I perceived what my career would be. There's not a single person at the Eye Institute that I have questions about sending my patients to. It's really nice to practice at a place where I don't have to wonder, do I want my patient to go to that person? And would I want that person to know that's how I feel about them? It's really nice to practice at a place where everyone is good. It's also really nice to be at a place where science is exploding, where there's a rankings called the Blue Ridge Rankings, which is where they look at support for vision science research, for example. And we're the 12th in the country at this point. We weren't there when I first came. And it's not because of me, it's because of the other people that have come since I came in the last 8 years. We have some of the most decorated scientists in the world in our department conducting vision science research. And we work together as a community in our department. And it's just a really exciting place to be. So I would like to talk about a couple of the advanced technologies and things that are coming out of our department. The first one is some advanced imaging. This is actually something that I do. I spend 3 days a week in my lab. I've got about 15 to 20 people in my lab. And one of my goals is to develop a cardiac stress test for the eye. So you run up a flight of stairs, you run out of breath. Well, maybe you have emphysema, but you also could have a heart that's not functioning and delivering oxygen to your body appropriately. Well, we can put a person on a treadmill, we can slap some electrodes on their body, and we can look at what happens to their heart as they walk on a treadmill or up some steps. Or you can do an ultrasound of the heart to look at the heart's movement under stress. And that's a stress test of the heart. It's a very common and has been around for a long time. There are similar tests in ophthalmology where you can flash a light in someone's eye. Everyone's had a photograph taken, maybe in a wedding or a photo shoot or whatever, and you get blinded for a brief period. And you want to quantify how long before someone can see again. That's the dark adaptation. That's going into a movie theater and seeing how quickly does someone adapt. But how do we quantify that? Everyone responds to a test differently. It's asking, can you see a light flashing after a bright light has temporarily blinded them? And it's a very subjective response. So one of the things I'd like to do is be able to take a photograph of someone's stress response. They don't have to say anything. They just have to look at a light and take a photograph. So one of the ideas is that we shine some light into the eye and we temporarily tattoo the retina. Temporarily provide multiple doses to the surface of the eye and look at the recovery over time. So we can take a photograph at different time points after a flash and see the recovery. And I'll show you an example of this. Here's a pattern that we flashed onto the retina, and we took a photograph about 5 minutes later, and you can see the pattern is fading. And we can quantify the color, the grayscale in the picture, and quantify the recovery. So it would be amazing is if we have an objective test that I can take to someone like myself or anybody else with a family history of macular degeneration and say, yeah, this is what your stress response is like right now. You have a high probability of developing macular degeneration because we know you have a delayed dark adaptation. Something else in my lab is 2-photon imaging, where we look at the molecules in the retina. It's like an optical biopsy of the function inside cells. What is the chemistry? And so we can see different animals here. This is from some of my colleagues, Grażyna Palczewska and Chris Palczewski, where we have different mice with different models of human disease. They have a genetic disorder that changes the way the retina looks. And you see a normal mouse in the top, and you see a normal mouse in the middle, and 2 different animal models of human disease above and below that. You can see that they structurally look very similar. But when we probe them with this advanced imaging technology, 2-photon excitation, we can start to see different patterns of biomolecules inside individual cells. And we can even see that if we analyze the light coming out of the cells, this is not staining, this is not killing, this is like non-invasive optical biopsy, we can look at the distribution of normal and abnormal biochemicals within cells. And using this, we could learn what is macular degeneration. Because guess what? I haven't told you what it is. We just know that people develop something that looks unhealthy, and then things start going bad and cells start dying. But what is it? And it's probably a family of different diseases that have a foundation in intracellular, inside the cell, biochemical failings. And so we've developed a human instrument for this in my lab in collaboration with them. And it's very sophisticated, and the goal is to be able to optically biopsy and learn what an individual person's biochemistry is. Another area of investigation is systems pharmacology. These are two of my colleagues. And the question is, can we gently massage specific parts of cellular receptors to make them behave better? So there's hundreds and thousands of drugs that have been approved by the FDA to be used safely for a variety of diseases. And what they have shown in a number of animal models is that you can take these FDA-approved drugs, meaning there's no millions and millions of dollars of investment to try and bring a drug to be accepted by the FDA and allowed in human use. These drugs are on the market already. But can we use them in an alternative, an off-label way, and in combination with each other to massage the retina? It's kind of a crude and lay way of describing it, but to make the cellular function of all the cells in the retina behave more normally, so that macular degeneration, diabetic retinopathy, other conditions don't cause vision loss permanently. I talked a little bit about gene therapy. This is a hot topic, and I want to make it really simple. We have a manuscript. We have a script for a movie, and that movie can have a whole section where it's a comedy, but it's a drama, or it's a horror movie, and that comedy section is in there, and it shouldn't be in there. And the reason why it got turned into a comedy section is because they used just a few words that were just too funny. We can say, okay, well, let's see if we can correct the script for the movie. We can try and fix the mutated script. One thing that has been going on for over 10 years now is gene augmentation. Saying, hey, that's that script. It's got that wrong one section that's wrong. Here's a different script, and it's going to go right next to it, and we hope that the actors read the right part of the script. We're going to put the correct gene next to the DNA in the person's body, but the DNA that's wrong is still there. So we're augmenting their DNA by putting the right, a small piece of DNA inside the cells in the body. That's called gene augmentation. Gene editing is actually where you go inside and you precisely manipulate a single base pair, a single word or letter in the script to make it correct. And this is what we have an army of people at UCI who are focused on this problem. And a lot of the world turns to my colleagues as leaders in this endeavor. It's very exciting to be part of it, because one day I might be injecting the stuff that they make in their labs. People are still always going to have advanced vision loss. When cells die, they're gone. How do we replace them? And so the idea is, can we create transplantable retinal tissues? And this is one of the first projects that I started working on when I joined, and I've been collaborating with Macular and Seiler. And the idea is, can we transplant tissues that are derived from stem cells? And so you take a stem cell, you convince it to not become any organ. It's not going to become a heart. It's not going to become a liver. It's going to become a retina. And it's going to be convinced, it's going to be coerced to become retinal tissue, a little ball of retina. We call it a retinal organoid. And there are organoids for other organ systems, but we look at retinal organoids. And then we take that organoid and we transplant it underneath the retina to try and restore the normal cells that used to be there. And Magdalene Seiler has shown in animal models of advanced vision loss that she can restore light perception that is measured by the animal actually tracking targets or measuring the electrical activity in the brain after an eye stimulus. My contribution to this is trying to develop a bioreactor that makes a piece of retina the same every single time, which is, we all want to have M&Ms that look like an M&M rather than morphed M&Ms that don't have their M on them, or they're joined together, or they're the wrong color. We want it to be reproducible. So with that, I just want to emphasize that the team that we have at UCI in the Department of Ophthalmology and Vision Sciences is not just an army of incredible clinicians, but it's a really impressive group of scientists. And we work right next to each other in these two buildings, the Gavin Herbert Eye Institute up there on the top right-hand side, and the Brunson Center for Translational Vision Research, which occupies the top floor of this brand new building directly next to the Eye Institute. And these are all the faculty in our department. And that's just a small portion, and you consider all the trainees that we have in clinical care and in scientific endeavors. And with that, I'll be happy to take any questions about anything relating to the eye. Repeat it.
Repeat it so that it gets into the recording. And maybe if you could stand up to ask your questions, and I will acknowledge you. Way in the back there.
During your research and clinical trials, have you found any beneficial efforts of saffron in ocular pathology?
Yeah, so there's a large group of scientists that look for naturally occurring products to try and benefit the variety of diseases. And certainly saffron is something that has, in primarily preclinical or tissue culture-based studies, shown to reduce oxidative stress. I'm not aware of any large-scale clinical trial that is investigating saffron for macular degeneration or other eye diseases. I'll tell you that you'll know when saffron is being used in clinical care, because the price of saffron will become much more affordable because it is being demonstrated, and a pharma company has said, hey, let's make a lot of that. So it might become affordable in clinic, at least a purified form, but it might become more affordable in the market.
Ask for the, let's say, 6 to 8 week injection for dry macular degeneration, Sulfogray or something like that. We see the commercials if you stay up late like I do. How long? I mean, if it's such a slow 20% in 1 year, 3 years, 5 years, if someone's young, are they supposed to take these injections for 5 years, 10 years, 20 years until the next best thing comes around? Is there any end in sight to the injection?
Yeah, that's a really great question. With the medications the question is regarding medications that are injected on every 6 to 8 weeks or 4 to 8 weeks for advanced dry macular degeneration. How long do people keep on taking it? At this point, we don't really know how long people are willing to keep taking it. Typically, once central vision is compromised, people become less motivated. Some people want to try and preserve their vision even after central vision is lost. If they're 2100, I've had one patient who says, I'm 2100, but I want you to please give this to me so I don't drop to 2400 over whatever time course. But we've only been using these medications in the real world for 2.5 years. And so
I guess what I'm asking is, once central vision is lost, there's 100% GA in that eye.
yeah. So
Then reach a point.
this comes down to personalized medicine. It all comes down to a conversation. And because these medications aren't the amazing miracle that we would like to have, like the other medications for wet macular degeneration have been, they actually aren't even approved in the EU. So in the US, in North America, we're kind of getting some of the first experience with them. And these conversations are things that I've had to learn how to have with patients, because how do you tell someone that I can't show you how much it's helping you? I'm not going to make you better, but in the long run, you're more likely to have vision for a longer time. Oh, sorry.
What is your opinion of the Valida treatment, which is the light therapy for the dry eye?
Yeah, so the question is about the photobiomodulation light-based therapy for advanced.
It's invasive radiation.
Yeah. So there's been some reports and an FDA approval for a new instrument where people look into a light source that has a very specific part of the visible band spectrum to stimulate cells in the eye and slow down the rate of progression of advanced dry macular degeneration. And the real answer to the question is there's not broad adoption of it in the field. It's not much better than the injections, and it's questionable if it is. And the devices still require someone to come in and look into a light for a certain period of time in a clinic on a certain interval. So we have not purchased a device at UC Irvine. I think they have one in some private practices around. We just haven't really bought into the efficacy benefit over the complement inhibition, which is the injectable medications at this point. Yeah, I would love to learn more about it in the real world over time. Yeah.
My voice carries, so I want to know.
There's just one question over here first.
Oh, excuse me. No, go right ahead.
I understand there's still another kind of macular degeneration. Well, actually, I have it, so I know it exists. But in my family, it's not wet or dry. I don't remember the name of it, but he describes it as wuzzled up saran wrap. I guess on the retina. And
Yeah.
my brother's had the surgery, which so far I don't need. What's the progression of that? If I stop going to my retinal guy, no, I might come to you, but if I stop going, but he wants me there every 6 months, and I'm getting tired of it. I mean, I ought to continue going, right, or come see you.
Yeah, so the question is related to Willy Wonka's diagnosis of the wuzzled up retina. So what you're describing is something called epiretinal membrane, macular pucker, cellophane maculopathy. It's the wuzzled up retina is a scarred retina surface, and you can do surgery to peel the scar tissue off the surface of the retina. And that's a surgery that we all do as surgical retina specialists, and it's very different from age-related macular degeneration. It's not really a degenerative process, but more of a scar formation that distorts the natural shape and smoothness of the surface of the retina. And it can cause waviness, or just we call it metamorphopsia, in a similar way that macular degeneration can cause metamorphopsia. But they're very distinct processes. Yeah.
Okay, this will be the last question.
Okay, I just wonder, of all of the new injectables, why are they so expensive? And secondly, have you found any one of the newer ones, like Eylea, that have more improvement, or people see improvement that's greater than another medication?
Yeah, so the question is, why are these injectable medications for wet macular degeneration so expensive? And that's a great conversation that people like to have with drug companies. They certainly aren't as expensive in the developing parts of the world, and there are a category of medications called biosimilars. It's kind of like generic ibuprofen versus Advil that are coming to the market, which are trying to obviously consume part of the market, but also have a price point advantage. It hasn't been as big as we hoped it would be. Having a medication that passes through phase 0, animal tests, phase 1, a small group of people for safety, phase 2, a larger group of people looking for the efficacy or how well the drug works, and phase 3 and to phase 4, which is post-marketing. All of that research costs hundreds of millions to billions of dollars, and so there are more drugs that fail than drugs that succeed, and so it's a very complex question why it has to cost as much, but that's what the argument is oftentimes made, is the return on the investment. And the second one is, which of these has the best efficacy? In certain contexts, there is some benefit of some of the newer agents. What I tell my patients is the floor is where we were when we were shooting lasers into people's eyes. Avastin, which is bevacizumab, which is a non-eye medication. It's used to treat colorectal cancer and other cancers. This is an off-label use of a medication. It's taking a very small small portion of a big bottle, a bottle that's used to infuse in a person's body with cancer, and taking a small piece of that and putting it into a person's eye for $50. That medication is not FDA approved for use in the human eye. It is the most commonly injected anti-VEGF medication in the world. So the most commonly injected anti-VEGF medication is an off-label use of a cancer chemotherapeutic, and it costs $50 to take that small portion. Now the whole bottle is worth, thousands of dollars, and then the on-label, the medications that have been approved for use in the human eye are somewhere between $1,000 to $2,000 typically. And which one's the best? I say they're all incredible. And once you start looking for nuances of improvement, it might be certain that it's, yeah, I mean, as long as someone's getting the treatment that which is one of these medications, they're doing a really good job, but they could be doing a slightly better job with some of the newer agents. And the cost of healthcare in the future is going to be really important because the gene augmentation, the therapy that's used for an inherited retinal dystrophy, which was approved about a decade ago, one treatment, which is a surgery to inject some liquid underneath the retina and to deliver DNA into cells. Anybody have any idea how much that one therapy costs? Not quite as for 2 eyes, close to that. So yeah, it's $800,000. At least that's what it was the last time I heard about it.
Thank you,
Yeah.
Dr.